So, on behalf of Center of Metabolic Surgery, the bariatric center that we run at Wockhardt Hospital, Hinduja Healthcare, and Zen Hospital, I welcome all the participants. This is the second one in our series of webinars on obesity and related diseases. This is not about bariatric, but this is about basic knowledge of obesity and how it affects health. I was past president of All India Association for Advancing Research in Obesity somewhere in 2007 and 9. And so obesity is very close to me beyond bariatric. And today, to discuss this important issue, I have with me three important panelists. Uh, the first is Dr. Hemant Bhandari, a senior orthopedic surgeon from Bombay Hospital. He also operates at Hinduja Healthcare, Khar. Then Dr. Rajveer Chinoy, he's a senior orthopedic surgeon at PD Hinduja Hospital and Hinduja Healthcare, Khar. And both of them are very close to me. I have worked in Bombay Hospital with Dr. Bhandari and with Dr. Chinoy in Hinduja Healthcare, Khar. And then obviously young Dr. Mazda Turel, a spine surgeon and a neurosurgeon with me at Wockhardt Hospital. All three are experts in their field, and we wish to share discussion and we wish to share knowledge with you on this important issue. Generally, when we talk of obesity, the major discussion revolves around cosmetic aspect, obesity and its impact on diabetes, obesity and its impact on hypertension, heart problems, but so little is discussed about the bone issue. And I'll tell you, this is probably the most important issue that we see when patient walks in our consulting room. They are either coming limping, or they are bent down, or they can't climb one step to an examination table because their knees are so bad. You see them everywhere. You go to the airport or you see them on the road. They are the senior people who are finding it difficult to walk. Some of them are breathless, but majority of them are because of their knees or hips which are not doing well. So obesity per se is a visible disease. It's a very common disease worldwide. We had done a survey somewhere in 2002, 2003 through Bombay Hospital in Mumbai, and we found almost 70% of people in Mumbai who are working class are overweight, which is almost at par as what we see in USA. Compared to that, osteoporosis is a silent disease because you don't see your bones getting weak. But we don't have much of Indian data. I'll ask my experts what is the Indian data. But in USA, almost 50% of 55% of people above 50 years have osteoporosis. And this leads to increased fractures, increased falls. And though women have more fractures, more men die because of these fracture-related problems. So, friends, let's move on. Let's get our experts involved. Let me ask the first question to Dr. Hemant Bhandari. Dr. Bhandari, what do you think is how can you explain what is osteoporosis and what is its percentage in India?
See, we get mainly postmenopausal women as osteoporotic because after menopause, the women tend to lose bone density rapidly. And especially we find in Gujarati, Marwadi women, or those who are a sedentary lifestyle, they tend to lose bone mass very fast and they are more prone to fractures.
Okay. And what do you think is the percentage of population that might be affected by osteoporosis?
Overall percentage is difficult. There is no big demographic surveys stating the number of percentage who are involved. But overall, in my clinical practice, I would say the postmenopausal women, at least 40% women post 50 years of age would be suffering from osteoporosis. I think other panelists also might share the same numbers if we ask them.
Okay. And what would be so one, you said this happens in postmenopausal women. So is it related to weight or is it related to the hormonal changes that happen in these women? You have not said this happen in men, in senior men.
It happens in women more commonly because of the hormonal changes as well, and plus hormonal changes because of the metabolic issues. They tend to gain more weight as the age increases.
Okay. Dr. Chinoy, would you like to add something to this?
Yeah, the percentage of obesity has not been defined, but
Yeah.
it is extremely common in India, not only in postmenopausal women, but in premenopausal women, as well as surprisingly in a large number of men. Since the DEXA became available, we got shocking results in younger women as well as in men across all ages. And I think it's a multifactorial thing. There's genetics involved, there's diet involved, there's sun exposure, vitamin D related, and there's an element of osteomalacia. So it is much more common than we think. And it's not related to age or being older. Yes, it is known to progress in some postmenopausal women, and it's refractory in some postmenopausal women, even to treatment. And the sad thing is, like Hemant said, in Gujaratis and Marwadis and in vegetarians, they seem to have arthritis, obesity, and a waddling gait. And if you check them, not only do they have poor D levels, they've also got osteoporosis or osteopenia. So it's much more than we suspected all these years.
Okay. So one thing that we have found common is that obesity and osteoporosis are not related to age. I mean, people say that as we age, our bones become weak. Is it true, Dr. Bhandari?
Who are you asking? Are you asking me or Hemant?
Dr. Bhandari? Yeah.
Yeah. See, it is a natural progression for the bones to become weak as we advance through the age.
Yes.
Our bone density, peak bone mass is achieved by age of 20-25 years of age. And afterwards, we decline at a rate of about 1% per year. The women tend to continue at 1% till they achieve menopause. After menopause, they tend to lose at 2 to 3% of per year. Bone mass. And in those 2 to 3%, there are 5% to 10% whom we call as a rapid losers. They are losing at a rate of at least 5 to 10% a year. So there is a small subset in those women as well who are losing bone mass rapidly.
Okay. So coming back to the topic of the day, Dr. Chinoy, how does obesity affect bone health? So one we realize is that the age itself leads to decline in the bone mass. But how is obesity affecting the bone health in general? We are talking of bone and not the joints at the moment.
Sure. Now, obesity, the thinner person has a tendency to osteopenia. The well-fed muscular person has protection against osteopenia and osteoporosis. However, paradoxically, if you increase weight and move into obesity, it inversely affects the bone health, i.e., the more obese you are, there are hormonal changes and your bones, but the bone strength tends to deteriorate. You would think that with carrying so much weight, the bones would be strengthened, but no, paradoxically, they tend to become more porotic.
So, normally as the slide shows, Dr. Chinoy, that when our BMI increases, the bone mineral density increases. So the bone becomes bigger, or bone mineral density increases. So what you are trying to say is this, that there are positive signals and negative signals.
Yes. Could you go back to the previous one?
That's fine. Yeah.
Yes, because you see, there is a level of mechanical load which is beneficial. Once
Yes.
it goes above that, it's the camel's back is broken. And as you can see, there is increased levels of the sex hormones and the conversion of androgen to estrogen and various other metabolic changes which are actually harmful to bone health.
Okay. So,
And now,
these are the positive changes and these are the negative changes. So, Dr. Bhandari, how do we explain this? What happens to the bone ultimately? I mean, Dr. Chinoy is saying overall it's negative. So, what happens to the bone in somebody who has gained weight?
See, people, as Rajveer said, those who are muscular tend to be better in the bone strength, but those who are tend to be obese with a high amount of fat tissue, I think there are some these metabolic changes which are taking place and which is affecting the bone quality. And these are all newer studies. The previous, we used to think that just by increasing the weight, your bone will be strong. But recent studies have shown because of these factors to be other way around.
So, what effectively you mean is that though the bone mass increases, but the bone quality deteriorates with weight gain, isn't it?
Yeah, the bone consists not only of the mineral constituents, there's the architecture, the trabeculae, and
Yeah.
the strength, the
Yeah.
quality of the bone.
Yes.
All these are affected by these hormonal changes.
Yeah, because in our practice, in obesity practice, a lot of patients come and they say, "My weight is more because my structure is big. I have big bones." A lot of people believe that they have big bones, but that doesn't mean that the bone quality is good. And how do you assess this bone quality? Simply in simple terms, how does somebody check out his bone quality?
no, and another thing, these
Yeah,
people who say that my family is big made, I
yeah,
have always been big. I have we have big bones in our family. That's just an excuse for eating and getting fat. There's no truth in that, and neither is there good bone health in those people.
yeah. So we will not go in that area, Dr. Chinoy,
Yeah,
about
but
obesity. But as far
no,
as bones are concerned,
it's just a practical thing, because in our practice, in general practice, people say, when you tell them, please lose weight, they say, no, we can't. We are all like this. Our whole family is like that.
that's true.
You see,
That's true.
that is one excuse not to do something.
So
But
one of the major problem that we are facing is obesity in children. Uh, Dr. Chinoy, what are the issues as far as bones are concerned? I mean, some of them have been listed here. Do you have any other issues in these children?
see, a lot of these children, structurally, the young obese person or the obese child, you will find flat feet, which is basically a pronated foot. If there are hormonal problems, or if the person is very small and fat, or tall and thin, again with the hormonal element, you can have slipped capital femoral epiphysis. And because the child has been overweight when the bones were weak and soft, they end up with either genu valgum or genu varum, both of which mechanically affect their knees and their gait.
So can you explain in simple terms what is genu valgum?
Genu valgum is called knock knees,
Okay.
and genu varum is when you get bow legs.
Okay. So basically,
And,
these people
and
can't walk straight.
both are seen in the overweight, malnourished, low vitamin D, or bad hormonal balance children. And these are of necessity the heavier child.
Okay. All right. So we go to the next one. Now, it has been seen, that the fat cells and bone cells have an inverse relationship. So within a bone, there is a bone marrow, and if you gain fat cells, you lose bone cells, and if you lose bone cells, you gain fat cells. And many of the diabetes medicines, many of them leads to increase in fat cells and bone loss. So, Dr. Bhandari, is it possible to give an idea of these medicines that causes this, or it's basically the steroids which causes this? Do you see such patients?
We do see patients which are, steroid-induced diabetic, people losing lot of their bone mass.
Yeah.
The way we assess them is by doing a DEXA scan, but that will just tell us the mineral content of the bone.
Okay.
The strength of the architecture, the collagen, we have no good test which we can use on a routine basis to assess that. So we are limited with that because that is the only clinically available test by doing a
So,
DEXA.
right. So these patients who are on steroids, are they at increased risk of fractures?
Chronic long-term steroid is a known risk factors amongst many others to
Yeah.
cause decrease in bone density.
And the same thing, the last point that has been put on the slide, if somebody is immobile, we have a lot of patients who are coming for bariatric surgery on a stretcher or on a wheelchair, or those who
True.
are not able to walk much. Does that also lead to loss of bone mass?
See, our body responds to the stress put on it. The bone is
Yes.
strengthened because of the stress. If somebody is immobile and there is no load going through the bone, the body absorbs this calcium, the bones become soft and weak. And suddenly, if they start walking, standing, many times they end up having stress fracture.
Even
People,
just by standing.
yeah,
Yeah.
people which arm or leg which has been immobilized, and if you take a X-ray, you will see
Yeah.
osteoporotic changes in those X-rays.
Okay. Yeah, sure.
Can I add something,
Yeah,
Raman?
sure. Yes.
Steroids
Yes.
act in three ways: directly with their own actions, two, increasing adiposity, and three, causing steroid induced diabetes. And diabetes per se also causes bone loss or weakening of the bones. So,
Okay.
steroids and diabetics both have a serious risk of developing early osteoporosis. And immobility,
Yeah.
anything which does not move becomes automatically weak. Not only do the muscles become weak, but the bones become weak. And because the muscles are weak, there's a further more profound effect on bone weakening, because there's no stimulation from the weak muscles, or there's no stimulation of mobility. So that
Okay.
it's a double-edged sword.
So what you are saying is it's very interesting. If somebody is exercising, that not only increases the muscle mass, that also makes the bone strong. Is it?
That's right, perfectly.
Yeah. Okay. All right. I just wanted to highlight that point. So, friends, this was about weight gain. Many of our patients who are on a diet or who undergo bariatric surgery, any kind of weight loss has its impact on bone. So, uh, Dr. Chinoy, what about effect on bone when you have weight loss?
Now, there are two types of weight loss. One is the person who is overweight doing their own diet without guidance. If they're doing their own diet without guidance, there is definitely malnutrition and hypovitaminosis happening.
Okay.
And post bariatric surgery, I would leave you to discuss that, because
Yes,
there
we'll
are
be discussing that. Yes.
different changes and different reasons, because that's a different kind of weight loss.
So, Dr. Bhandari,
Basic diets.
Yeah, sorry.
People say, I have gone on a fruit diet, I've gone on a soup diet, I'm only having boiled vegetables. See, all these are without guidance, something developed at home, and they're trying for weight loss, but their weight doesn't get lost. What they're losing is proper nutrition, and with it, it compounds with bone weakening.
Right. So, Both obesity and weight loss are risk factors to bone health. And this is important to realize that you need to have a homeostasis or maintain your weight in a healthy zone. And as the orthopedic surgeons, both of them are saying that try to exercise regularly so that the bones become strong. It's not about the muscle. So now this shows that there is an increased fracture risk in elderly when they have weight loss. Is, as you have mentioned initially, that osteoporosis increases with age. So how is this? So if some elderly person is exercising regularly for years, does he or she reduces his risk of fractures and falls, Dr. Bandari?
Yes, it does. See what happens with the aging changes, not only the bone, muscles, the nerves, everything gets affected. Those who are in a regular heavy physical activity and exercise, we find their coordination to be good, their bone strength is better, and they're at a reduced risk of having fractures.
Great. So we will talk about this issue at the end of the talk today, end of the program, about how we can avoid this the bone loss when you are in a weight loss phase. A lot of
No, also,
patients,
also
a lot of people, even in society, are trying to lose weight, and how they can lose it healthy way by adequate nutrition so that their bones don't become weak. We'll be talking at the end of the program today.
also Raman,
Yes.
you'll have to highlight what changes or what additions you have to make to your diet after bariatric surgery, which is osteoprotective. What are
Sure,
the things?
sure.
As
Will
far as, as far as bone preservation when you become old, just exercise is not the thing. You've got to do exercises which improve your balance and your coordination and muscle strength. Now, this is toning the muscles. We are not doing bodybuilding. So,
Yes.
toning the muscles, balance, and coordination. This is protective towards the elderly, and it prevents their bones from becoming weak. It prevents them from falling because it's the balance, coordination, and avoiding falls, which is the most important thing in the older person. Because if you start falling, regardless of that, if you're old, you will break something, and you want to protect against that.
Okay, that's wonderful. So before I go to Dr. Turel, one follow-up question to Dr. Chinoy again is uh, a lot of people in India think that walking on a beach or walking on the road is a good enough exercise. So when you say that we should have better coordination, toning, and muscle building, should it be done on in a gym, or one can do at home, or is just walking enough?
See, a lot of people see our body. We are human beings. Our
Yes.
body was not made for running. So a lot of people feel that running it's a good cardiovascular exercise, but it's not great for the joints. The ideal exercise is walking. Walking on tarmac or a hard surface is harmful to the knees.
Okay.
Okay, but walking on soft sand on the beach may feel you may feel it is easy, but if you have a long walk in soft sand, it strengthens your knees, it strengthens your ankles, it strengthens your hip. It is very proprioceptive improvement, and it's more strenuous than walking on flat ground. Now, obviously, in the monsoon, if it's wet outside, you do not want to fall on wet leaves and moss, so you'll be using the treadmill. But that's just the few months of monsoon. But for the rest of the year, find a good place to walk, wear good, well-fitting, supportive shoes, and brisk walking so that you break a slight sweat. Don't overdo it, and don't go mad with running miles and miles.
Okay. All
Can I
right,
add,
we'll come back to you.
as we
Yeah,
are
sure.
on the exercise thing, see,
Yeah.
a lot of obese patients have knee arthritis symptoms. So,
Yes.
a lot of them are advised to walk in a chest deep water in a swimming pool so that
Yes.
the buoyancy of the water takes away the load on their knees and they are able to get the exercise and spend their energy.
Great. We will.
Walking for
Yeah.
obese people or anything, they hurt their knee. They are not able to do that. So walking in a swimming pool in a chest deep water, though they may not be able to swim, but in chest deep water they will be able to walk the width of the pool and get the
Okay.
exercise.
Great.
Yeah, Raman, may I add one
Yeah.
small
Sure.
thing? You know, things like aqua aerobics, or
Yeah.
if you go to an aqua center, like there's a specialized place with a swimming pool and qualified physiotherapists. It is not only, it's called aqua center, I think. And these things are very important for the older person, for the obese person, and for the person who's rehabilitating from a knee injury before it's good enough to get onto normal mobilization and strengthening. You can do a lot of stuff because you're 1/6 your weight when you're in water, and you can still do exercises, and the feedback from the muscles will improve the joints and the bones. So aqua center, aqua aerobics is very good.
Great. So, friends, we are getting a lot of questions from you. We will take them all at the end. There are a lot of things to be discussed, but we'll take each of the questions. Please keep sending your questions. We shift from overall discussion of bone to specific issues. A very large number of our patients, almost all of them, including the surgeon themselves, have backache problems. And when you have backache problems, it physically limits us. And the obese people, people who are overweight, have all the more issues. So we have Dr. Mazda Turel, who does a lot of spine surgery at our hospital in Wockhardt Hospital in Mumbai, is with us, and I invite him now. So Mazda, before I move on, can you give a little background on how what the spine is in a very simple terms, quickly, and what is the impact of obesity specifically on spine?
Thank you very much, Dr. Goyal, for having me in this enlightening session. So, really, actually, if you look at spine, you should look at the entire spine as a single organ, as a separate organ. While it's a bundle of columns, 33 vertebrae bunched up on top of one another, with the intervertebral disc separating them. The intervertebral disc actually acts as a shock absorber and takes away the impact that you have. But the real load is actually born through the facet joints of the spine, which are more laterally placed. And the thing about obesity is not it's not only bone related. See, 90% of spine pain is musculoskeletal. Very little amount of spine pain is actually nervous spine pain or neurological spine pain. Most of it is musculoskeletal and arises from not from nerve root compression, but from muscle damage, from muscle wasting, from and from the bone and from the disc. So, like the slide rightly says, it's multifactorial, and a lot of it is mechanical, a lot of it is inflammatory, and of course, there is, like to everything else, a genetic basis to it. So, especially in the obese patients, a lot of this, what happens is that the center of gravity shifts, and you have this extra strain on back muscles, and it leads to an abnormal posture, and that abnormal posture results in a vicious cycle of decreased range of motion and stress on the bone, and that cycle keeps repeating itself, and that results in enormous pain and inability to carry out activities of daily living.
Mazda,
So,
one quick question. You mentioned that the center of gravity shifts. I mean, why would it shift in an obese person?
because of if the patient has a lot of belly fat, and
Okay.
that's where most of their weight is focused on. It's like in some sense, it's like being pregnant. That is the exact same reason why a lot of pregnant women have back pain. While their muscles and ligaments are getting stretched, it's the belly that actually takes the weight of the spine and increases the lumbar lordosis, and that results in an abnormal curvature. Like ideally you want lordosis of the spine, but excess lordosis also is not a good thing. And
Okay.
then obviously you have disc degeneration, results in arthritis, and eventually when it gets worse, either due to facet joint arthropathy or due to instability which results, you can get sciatica and back pain, and then neurogenic claudication, etc.
Okay. So, before we go on the preventive aspect, when these patients come with significant back pain, which is not getting relieved with normal painkillers, sprays, and ointments, and all those things, if they come to you for a spine surgery, a patient who is significantly overweight, is this a risk factor for spine surgery? I mean, what is your experience on this?
Yes, definitely. My experience has been that obesity is definitely a risk factor. But what is changing is the kind of surgery that we are doing, which is now negating that risk. So when we traditionally performed open surgery, we had larger incisions. It was lots of more retraction. The muscles used to get retracted for longer. There used to be ischemia of the muscles, and the wounds did not heal as well. But when we've shifted the focus to minimally invasive surgery, with much smaller incisions and a tubular retractor doing the retraction in a regulated fashion, rather than retractors pulling on the spine, a circumferential retraction, uh, you have, in my opinion, the outcomes are comparable, except for, if at all, the wound still sometimes is an issue in obese patients. But overall, actually, to be honest, the revolution of minimally invasive surgery is much better for the surgeon, because he's using specific instruments in a very precise fashion, and that the 1 hour, 1.5 hours that was required to expose the spine for 3-4 levels is now completely negated by the technology that is available to us. So from a surgeon's point of view, obese patients, if you're performing minimally invasive surgery, it's great. If you're performing
Okay.
open surgery, it's a nightmare.
But
um,
majority of the surgeons would still be doing open surgery, isn't it? Very few people who are highly technically skillful are doing the minimally invasive spine surgery.
uh, Yes, but it depends on it depends on which surgeon you go to. A lot of the current generation is doing minimally invasive surgery.
Yeah.
But
I would say
Mazda,
yes, sir.
aren't there specific indications where minimally invasive is possible and open is required? Can you elaborate on the difference between these two things?
Yes, sir. So, in my opinion, about 70 to 80% of regular routine degenerative spine surgery can be done in a minimally invasive fashion. uh, unless you're correcting some major deformity and there's a big rigid scoliosis or a rigid adult degenerative deformity where you require multiple osteotomies to correct the deformity. All degenerative disc problems can be dealt with in minimally invasive surgery. All 1 to 2 level listhesis, spondylolisthesis, can be dealt with minimally invasive operations. So the
Okay.
bulk of degenerative work,
Can
the
be
bulk
done.
of degenerative patients that come to us can be dealt with the help of minimally invasive surgery. And actually, to be honest, the outcomes are really good. Even in obese patients, they are out of bed, if not the same day, the next day they're walking and they're discharged within a couple of days, as opposed to when we used to keep them in bed for several days before even thinking of mobilizing them, worrying about what would happen to the instrumentation, etc.
So
Uh,
basically, the minimally invasive creates much less soft tissue trauma and
Exactly.
better healing, better lower risks, and better outcomes.
Exactly. And even reduces the rate of infection, especially when you're talking about obese patients. And the muscle damage that you see on a post-operative MRI, the difference between an open operation and a minimally invasive operation, it's been measured statistically. It's way better.
Raman, can we ask Mazda to talk about this hyperlordosis and a lot of resultant or separate kyphosis which happens, which causes upper back pain and lower back pain, if we've got a few minutes?
I think his screen is frozen, but if you can hear me, I'll continue talking.
I think
Can you hear me?
Go ahead.
Hemant is moving, but Raman is frozen.
Yeah.
Hemant, move your hands.
Yeah, I'm here. So I think we can continue till Raman can join us back.
I think he must have out and we'll come back.
No, because this
What happens is,
upper back kyphosis in the last year or so has started affecting even me, and
correct.
I consider myself fairly fit, and it's important when you're a little on the older side that even if you're exercising, certain amount of degeneration is going to happen. So how do you avoid getting back pain in those states and also in the obese state?
Yeah, so for regularly as you age, life, basically, if you look at life is a kyphosing event. If you just look at how evolution takes place from childhood to the geriatric population, over the years, everybody trends to kyphose. So to prevent that, you have to really be very mindful of your posture. And now that a lot of work is becoming desk-related work, a lot of people tend to be in front of the computer for long hours. A lot of surgeons who are operating for long hours tend to slouch. So exercises to improve the muscles of the upper back, which is really the key. More than the bone, it's the muscles that degenerate and waste, resulting in their hold on the spine becoming poorer, in effect the spine kyphosing. So if you have a problem and you're tending to, and the increased kyphosis results in pain, obviously, eventually, because there's some amount of micro instability that takes place beyond the normal range of motion that the spine is used to. So exercising muscles of the spine separately is extremely important. Posture is the key. The idea is to avoid sitting in any one position for more than 30 minutes at a stretch. If you are sitting, then you stand and stretch. And if you're sitting for long, it might be worthwhile to wear a posture corrector or a brace, like the ones you all give for clavicular fractures, a figure of 8 brace that pulls the shoulder back. And a lot of these are available in the market. And that actually prevents you, at least reminds you from allowing to slouch, and you keep that upright posture as far as possible.
So what you're trying to say is you should improve your back extensors and your scapular retractors.
Exactly.
Raman is back.
Hi. Yeah, sorry, there was some internet connection.
When you got to go, you got to go.
So,
you can put up the slides. Can I ask a question to Rajveer and Mazda? What
yeah, please go ahead as I
face during the surgery for obese patient? What are the risk factors for surgery?
No. What are the risk factors for surgery in the obese?
In obese patients, what are the common problems that you would face?
So, as far as spine surgery is concerned, you're asking Dr. Chinoy?
Either of you, yeah, both of you.
No, Mazda, please carry on.
I'll be very brief. As far as open spine surgery is concerned, it's only blood loss and wound healing that's an issue. Apart from that, everything else is the same. As far as minimally invasive spine surgery, there isn't really much of an issue, except in a few patients where wound healing may become an issue. Blood loss is never an issue in obese patients in whom you operate minimally invasive. But for joints, the problem might be slightly different.
Well, if I may just say,
Yeah.
surgery in the obese, one, if it's elective,
Slides.
I will discourage them from having the surgery, or I will flatly refuse. If they are grossly overweight, I have actually refused patients who've come for a hip or a knee replacement. If it's for fracture surgery, then the risks are DVT, infection, local tissue complications, wound healing, and difficulties in their mobilizing post-fracture fixation. And all this has to be very clearly explained to the patient and the relatives. And it's important to document that there are going to be complications more than the normal patient. Raman, we can't hear you, Raman. We can't hear you.
You're on mute.
Raman, you are muted.
Can you hear me now?
Yeah, and then put full screen.
Yeah, 1 second. Yes.
Perfect.
Now,
Full
so
screen.
I think this is where we were. Yeah, it will come on full screen. So, besides the risks that you have narrated, there are also risk factors from the associated diseases like diabetes and breathing disorders. And it is known that, those who are more than 40 BMI, morbidly obese people, that itself is a risk factor for complications and readmissions.
Can you explain this BMI thing? Exactly.
BMI thing, I think most of the doctors who are attending this knows this is the body mass index. So it averages out the height against the weight. So those who are at least 25 to 30 kg overweight, they are about 40 BMI. So those who are significantly overweight, 25 to 30 kg overweight, are at a high risk for complications and readmissions after surgery, any surgery. Now, Mazda, would you tell me that the outcomes of surgery? So one thing you said was that the outcomes are overall okay in quite good when you do it a minimal access surgery, but are they as good as those who are in non-obese persons? Surgical outcomes.
Definitely not. But if you look at post-operative mobilization, etc., is definitely more and longer in obese patients than in non-obese patients. But if you look at them as far as their pain goes, which is what the objective of surgery is, I think it's comparable.
Okay.
The recovery, and the healing, and the going back to work may be prolonged, and activities of daily living might take longer to attain independently. But from a pain point of view, if you look at immediate relief as well as at 1 year, they would be comparable.
So one is that obviously there is a problem because of obesity, but if they don't have the surgery, compared to a non-surgical treatment, is it a significant improvement in their life after spine surgery?
Oh, definitely. You won't believe it that we had an extremely obese lady, about 160, about 150 kilos or something, and she had an extremely bad spine. And because she was not able to walk because of the pain that was radiating down to her legs, and we fixed her, and she lost 30-40 kilos after surgery just because of the fact that she could walk and exercise and without pain. And then she actually came back and got both her knees replaced at our hospital. So, and if I tell you what she was pre-op and how she was walking compared to what she gained after surgery, I think you have to be able to select these patients correctly whose pain is actually due to neurogenic complications and is due to nerve pain rather than muscle and bone pain. And if the pain is due to a specific instability, if there's instability causing the pain and that is causing nerve root compression, I think that is the pain that should be addressed if it's feasible to do so. And
All
just
right.
postponing surgery, because that allows them to break the vicious cycle and allows them, because they say if they are in pain, how are they going to exercise? That is the other,
Absolutely.
and you can't give them painkillers all their lives. So you have to have some point where you can break the vicious cycle, and then it actually really benefits them greatly.
I'll show you some evidence at the end of the program, which shows that just because they are able to walk better doesn't make them lose weight. So, okay, so let's move on to a protective one. Are you able to
Other
hear
way
me?
around, also, Raman, is true. If they lose weight, they walk better. And if they lose weight, they
Yes.
don't come for knee surgery so quickly. They can hold on for more time.
I think it's a complementary things, So if they lose weight, outcome of knee surgeries improve. We'll discuss this at the end. So, Mazda, can you briefly run us through how somebody who has a early back pain avoid worsening of symptoms of his or her back pain? You have given me these slides. I'll go through them. You can show what are the correct postures. So can you explain
Yes.
them, and then I'll move to next.
So the real important thing is to avoid any kind of constant strain. So the bottom line is not to be in any fixed position for more than half an hour. So if you're sitting for more than half an hour, then take a break and stand or stretch. If you're standing for more than half an hour, take a break, sit, and that break just has to be 15 to 30 seconds. It does not have to be a 5-10 minute break. It's just that you don't want those muscles to be in constant strain and constant stress so that they become weak. When you sit, it's extremely important that your bum is within this right angle of the chair. There is no space, there's no gap for you to be able to put your hand or to be able to put your finger. You should push your bum right behind into the right angle of the chair, and sit with your shoulders broad and your eyes straight. If you're
Okay.
tending to look at a computer screen, then you need to adjust the screen so that your head is maintaining a horizontal gaze rather than tending to look down. I think that's the best way to sit. Now, if you're sleeping, the ideal way to sleep is to sleep sideways. But if you're someone who sleeps on their back, then it's great to be able to put one pillow or two pillows below your knees so that your knees are in slight flexion. The slight flexion, what it does is it tends to open up the spinal canal and avoids any pinching of the nerves. But the ideal position to sleep is on any one side with a pillow in between your knees, and you can see how beautifully well aligned and balanced the spine is. The important thing to remember is to be able to maintain the curve that nature has uh, wanted us to be in, to be able to maintain it for as long as possible. So
So,
that's the way
Mazda,
you sit properly.
we have these morbidly obese patients who sleep always on their tummy. They find it very difficult to sleep straight because they get breathless. And so, how that can be helped? Any specific instructions for that? Hello.
I'm sorry, there was a lot of disturbance. I could not hear the question
Yeah.
after the morbidly obese patient find it difficult to
So
sleep on their tummy.
they sleep on their tummy. They can't sleep on their back.
So I think sleeping on your tummy is not a good idea. If they can't sleep on their back, then the best thing would be to put them on their side,
Okay. Okay.
and
Yeah.
you can use a neck support pillow, or a pillow between their legs, which will help them sit on their side. And
Okay.
again, getting out of bed is critical. We usually just don't think about how we get out of bed. We just get out of bed in one jerk. But if we can use our hands, the force of our hands to get out of bed rather than use the spine to get out of bed, then you are going to put less load on the spine, because getting out of bed requires a lot of spinal muscle flexion and extension. But if you take that load off the spine and put it on your hands, and you first turn on your side, put your legs down. If you look at the second picture, put your legs down first, and then push your hands up and get up. That is the ideal way to get out of bed. So if you can do that mindfully every morning, it's that way you're going to reduce the strain on your back. If you before and similarly when we get into a car, and I think this particular thing applies for the hip and knee as well, because a lot of wear and tear happens. We usually don't think about how we get into a car. We just open the door, put one leg in the seat, and then wheel the other leg in. But the ideal way to actually do it is to sit with both legs on the seat and then swing both legs together simultaneously inside, with using the support of the door and the steering wheel as your support with your hands, and then sit in the car. Similarly, when you get out, you use both your legs to get out, place them on the floor, and then get up, rather than doing one leg at a time. And that is what causes this asymmetric wear and tear in the hip as well, probably in the knee also, and definitely affects the spine. So a few mindful activities, like how when we have a heart attack, we are mindful of the cholesterol intake and taking a daily walk and all of those things. But for the spine, it's the daily posture that we maintain, how we sit, how we sleep, how we stand, how we walk, is what will determine the long-term well-being of an individual's spine.
Okay, thank you so much, because our obese patients have a lot of issues with the spine. The bones are already osteoporotic, and if they can maintain good posture, they can probably protect their back for longer time, and they can avoid a surgery for their spine, hopefully, and they can live healthy. So we'll come back to you at the end. We move on to the impact of obesity on other joints. This could be knee joints, hip joints. So what is the impact, Dr. Bhandari, of obesity on joints? How does it increases possibility of arthritis? Which joints are mostly affected, and how they are affected because of obesity?
Obesity affects mainly the lower limb joints, right? Starting from midfoot arthritis, knee arthritis, and to a smaller extent, hip arthritis, which we commonly see. In the Indian population, it's mainly the knee arthritis and foot pain which the patients come to us. And at an early age, we are seeing the advanced
Okay.
arthritis changes.
Yes. So is it all because of the excess weight, or are there any other factors into it?
There are other factors as well, apart from weight.
Yeah.
Apart from lower limb, other upper extremity is also affected because of the excess load on the muscles and tissue. The patients are getting shoulder pain, shoulder stiffness, frozen shoulder, and other aspects as well.
Yeah. Okay. So, Dr. Chinoy, uh, in these obese patients, what are with joint pains? What are the treatment measures? I mean, obviously, everybody is not going for surgery. So, are there any conservative measures, and what are the outcomes of those conservative measures?
So in the obese, let's stick to just the obese persons,
Yes.
right? And there are, obviously, it depends on at what stage of the disease they come to you, grade 1, grade 2, grade 3, grade 4. If they are mild to moderate, then we tend to treat them conservatively. We advise them, number 1, to lose weight. Number 2, to sort out their diet. Number 3, we refer them to a physiotherapist for regular exercise, and it's exercise, improvement in posture, and how to improve their activities of daily living. And then we use medicine as a backup, and supplements like chondroitin, glucosamine, collagen, etc., calcium and vitamins, etc. Now,
Yeah.
if it's coming to surgery, for one, this is my opinion, I'm not too happy about operating on the high BMI patients and the morbidly obese patients. I have actually, in fact, refused on many occasions. And I feel that it was good I refused, because I have seen the results of severely obese people being operated and having complications. And I wasn't, you realize that it was good you left, you didn't do the surgery. But eventually I heard the other point of view, that they are not going to lose weight. So let us be kind to them and do the surgery. But then when you do that, you open yourself and the patient up to facing severe complications which are listed and have occurred in the morbidly obese patients. So it's always better to, number one,
before the surgical management,
or refer them to a bariatric surgeon to get their weight down near an average weight for that height before you embark upon anything surgical. And in losing weight, they will do their medications, you will see their motivation, and you will get a better outcome of surgery if they are nearer normal weight.
Okay. So tell me one thing, you have sent a patient for weight loss to a dietitian or a bariatric surgeon, and the patient has lost weight, let's say 10 kg weight or 20 kg weight. How much impact does it have on the knee joint? Does it improve 20%, 50%? The symptoms completely disappear? What do you experience when they have lost weight?
Yeah, Raman, this is very variable from patient to patient. But losing 2-3 kilos gives a high percentage of reduction in the symptoms. I.e., little weight loss gives a lot more benefit than you expect. You think, okay, the patient has lost 2 or 3 kilos, but their benefit is huge. And it also improves their motivation, and it takes them to take steps, makes them take steps to increase more weight loss. So like you said, in the 1 pound of body weight places 4 to 6 pound of pressure. So when you reduce it, again, you get exponential benefit.
Great. Yeah.
Also, what happens is the activity of daily living improve, and they don't feel so necessary to go ahead with the surgery. They say, I can still manage with the weight loss.
Yeah.
There's a lot of happiness which comes with weight loss, and there's a lot of improvement in mobility, and there's a lot of reduction in symptoms. And they will thank you, and you feel happier that you drove them to lose that weight.
That's right. So if that person, Dr. Bhandari, as you were rightly saying, that their symptoms improve, does it mean that they delay a knee surgery, or should they still go ahead? Because they have lost weight, symptoms have improved. If they get the surgery done at this time, the outcome of your surgery will be better, isn't it?
That may be true, but we tell the patients that you do surgery if at all it is very necessary for you. It doesn't depend on the X-ray. It doesn't depend on what their peers are saying. But if their activities and their symptoms are manageable, so we advise them to go ahead and manage with the conservative treatment. And if it doesn't work, the surgery is the last resort.
Okay. So as the slide shows, that the osteoarthritis percentage improves many-fold as the person's weight increases. So this is an important component. And Dr. Bhandari, is it true what is written here? We found it from the literature that somebody who is obese may require knee replacement almost 20 times more than somebody who is normal weight.
I think it is more on a higher side, but obese patients tend to have a more requirement to have a knee replacement, because usually we'll find a knee to be quite arthritic in the advanced grade, as compared to their age and their contemporaries.
Okay. Now comes the risk factors. So a lot of people who are advised the surgery are very scared about surgery and related issues. I have seen a lot of people moving around by evening nowadays. The knee replacement surgery has become so safe in good hands. So, what is your experience when somebody who is overweight or obese undergoes surgery? Dr. Shinoy, how does it affect? You have already said that you would rather wait for their weight loss, but the person is not suitable for bariatric surgery. This person is only 10 kg overweight and is not able to lose. Now you have to do it because patient has severe
10,
symptoms.
10 kilos is not bad. Most of us in Bombay are 10 kilos overweight. So let's not, I'm talking about the very heavy people. And
Yeah.
now hip and knee replacement is shifting towards lesser and lesser days of stay.
Yes.
Okay, time spent in hospital is being reduced drastically. I have friends in the US, and there are studies in the US of daycare total knee replacement. You come into the hospital at 6 in the morning and you go home at 3 or 4 in the afternoon with a total knee replacement.
Yes.
And this is a full total knee replacement, not a unicondylar. And the similar thing, it's 24 to 36 hours for a hip replacement.
And in India, on average, in good hands, what would be the hospital stay for knee replacement?
The tendency is 3 to 5 days now. I think Hemant would also go with about the same sort of timing.
3 to 5, and again, patient factors also.
Remember, all these patients should be counseled. They should be fully assessed. The anesthetist, the medical person, and the team, everybody should assess them, counsel them, and everything has to be done with a certain amount of skill and experience so that you avoid complications and get them mobilized sooner and get them home as soon as possible. And that is not possible in the morbidly obese because there's a huge increase in the number of complications. And Mazda also spoke about the same thing. Soft tissue healing, wound infection, delay in wound healing, and poor mobilizing with other problems like DVT and cardiovascular complications. And also the long-term benefit of implanting joints in the morbidly obese is they don't last too long. In a person of normal weight, a well-done knee replacement with all the new materials today easily lasts from 14 to 17 years, and hip replacements are lasting 20 years now. So, but if you have an obese person and it starts wearing out in 7 to 10 to, in that 7 to 10 year gap, you're going to have to take on a revision in again a morbidly obese person when they're 10 years older, which will become 10 times more difficult and complicated and risky.
Okay, Dr. Chinoy, thank you. Dr. Bhandari, this is the negative side, but those who are looking for a knee replacement and they are not going for a bariatric surgery, refusing to go for, not motivated enough, is it still better than not doing anything because they are unable to walk otherwise?
But see, we have to counsel the patient because of the higher risk.
Yes.
If they are not going to lose weight and are going to go for a knee replacement, all its inherent risks are to be taken by the patient. They need to be counseled well. And
yeah, that's fine. I mean, they are ready to be counseled. Yeah.
Yeah, but ideally they should lose weight and then go for the knee replacement. Then they will get the maximum benefit of it. Otherwise,
so Dr. Bhandari, what about hip replacement? Is it the same as a knee replacement?
Hip replacement also, because in a morbidly obese patient, we require a special equipment in order to see the hip replacement is not a minimally invasive surgery. It requires a huge exposure, and obese patient, the exposure becomes still more higher, even to reach down to the hip joint, and associated wound oozing, associated dislocation rates, infection rates, all are higher. Time for surgery is higher,
Okay.
and
So
complications also are
basically,
higher.
sorry, please continue.
Yeah, so complications are also higher. So hip replacement in an
Yes.
obese patient is also at a higher risk than a would be a normal hip replacement patient.
Okay, great. So I think this is about the joints overall, that we realize that it is always better to have weight loss before surgical intervention, and then we think of a surgical intervention to have a longer life of implant to avoid immediate complications of surgery. So now the question comes, how do you achieve that weight loss? It's easily said than done. Majority of the population worldwide is struggling, and this is what probably Dr. Chinoy was referring, that American Association of Orthopedic Surgeons says that if you are planning a orthopedic surgery, patients should discuss and consider the impact of their weight on possible complications. This is a necessary discussion that should happen. They should they should talk about what are the possible options to lose weight before surgery. A delay in surgery is a risk reduction tool. Many times patients come and they say, we have so much pain in the knee joint and we want surgery now. We don't want to wait any longer. But one must realize it's in the interest of the patient that an orthopedic surgeon is advising them to delay the surgery. Everybody wants to operate, but they want to be safe. And consider delaying a joint replacement if weight loss could improve treatment outcome. Even after surgery, patient must keep weight down just because they had a surgery and pain has gone. They should not forget that they are overweight, because it not only keeps the weight down, it also helps improve the longevity of the artificial joint, as Dr. Chinoy had mentioned. So we go quickly to the weight loss and this part. Now, what is known scientifically is that all lifestyle interventions lead to about 5% of weight loss, 5 to 10% weight loss, let's say, which includes diet and exercise together and behavioral changes. While medical management, the medicines for weight loss are very few patients where it's indicated, where they are about 20, 25 kg overweight, and it takes 70 to 100% extra weight loss. And surgery is required because after lifestyle intervention, that means diet and exercise, 90% of them will regain the weight. Where the weight loss is 5 to 10%, and the other side there is a surgical intervention like bariatric surgery, where weight loss can go up to 100% depending on many factors, and people are able to maintain it long term. There are studies to show this, that these are the patients who are awaiting orthopedic operations. I'm going to talk only in relation to orthopedics today. 89% of them, because the orthopedic surgeon said that you 55% of them were not able to lose the expected weight, and 25% of those who lost weight were not able to maintain weight. So weight loss without, and those who had surgery, their gait speed and ability to climb steps, all this improved within 3 months of surgery. So it's not that you need to wait for a year before you think of orthopedic surgery or have improvement. It's not there. To 11%, hip pain
Raman,
also
we are not getting a sound signal.
reduced almost 80%. Hello.
We lost some of your sound from the beginning of this slide.
Okay.
Now you're clear.
Okay. Thank you. Now, this is not about advanced patients with advanced arthritis. Even those who came with early arthritis, if they had a bariatric surgery, at 3 months with just 6 BMI reduction, the joint space increased by about a millimeter, and that leads to significant improved in their symptom score. So I think bariatric surgery has a lot of role to play in those patients who have mild or advanced symptoms of joint pains. Now, post bariatric surgery, there is reduced hospital complications after joint replacement in both knee and hip joints, reduced risk for 90 days complications for the knee replacement specifically, though there was no impact on revision risk for either the knee joint or for the hip joint. So these are some of the evidences that are available, and that shows that, as Dr. Chinoy rightly said, that if we delay a surgery, it has a benefit in terms of this is probably the most important slide, that people who lose weight, as we have discussed earlier, they also lose the bone mass. Now, this is not new to our bariatric patients. All of them are advised 1 gram of calcium intake with vitamin D. And this is more important in elderly people, elderly postmenopausal women or men also. If they take this, the bone mass reduction doesn't happen to that extent. If they have enough proteins, which should be at least about 24% of the diet, it helps in reducing the bone loss. If they have enough vitamin D improves the calcium absorption, so they have better bone health. And if they are exercising, and we have discussed about exercise, with weight loss, it reduces risk of falls and fracture because it improves the balance of the person, and it gives the strength to the bones. So maintaining muscle mass with exercise during weight loss maintains loading advantage on bone. So I think what we have discussed today is obesity and weight loss both are risk factors to bone disease. We can avoid risk when you're losing weight. So weight loss is important, and it helps you in improving your bone health and avoids problem. I'll just show you one slide of a patient whose identity has been hidden. We operated her somewhere in 2009. She was 107 kgs, and even after 11 years, and she actively exercises, she's maintaining her weight almost 40 kg less, and is absolutely fit. So, friends, before we go on the take-home messages, we would like to take expert opinion of all of these. But just to summarize some of these messages, obesity and bone health are closely interrelated. Both weight gain and weight loss have adverse impact on bones, not on the joints though. Obesity results in joint pains, limited mobility, and increased risk of falls. Obesity results in higher complications of bone surgery. Weight loss can help reduce joint pains and joint surgery outcomes. So when we are talking of weight loss, we are not talking that surgery can be avoided. Surgery outcomes will improve. Bariatric surgery can help in significant and sustained weight loss. And weight loss associated impact on bone can be minimized with adequate nutrition, supplements, and exercises. So I think I'll stop sharing this. And before we take questions, may I ask my panelists to quickly, in a minute each, give a message to the viewers, the doctors, and some of the patients, general public, about the health. So starting with Dr. Chinoy.
I think before we end, thank you, Raman, for arranging this. I think it was very informative and educative. And the most important slide was your last one. Then we wouldn't have had to be sitting for 1 hour for this. But I was glad to hear. I was glad to hear all the points which came up. And the thing is, I just want to say one thing. Any surgery is a risk-benefit ratio. And if there's obesity is going to cause great risks, I don't want to take them, and I don't feel the patient should take those risks. It's important that they lose weight, improve their bones, improve their joints, improve their function, and then only after that, after losing weight, if the surgery is absolutely necessary, they should go ahead with it. I think that's my summary of it. Yeah, look after your bones, keep your weight down.
Dr. Turrell?
I think if there's only one take-home message, then for anybody, as far as spine health is concerned, it should be to keep mobile. Try and involve yourself in any kind of activity. You may not be able to do vigorous activity, you may not be able to, but just moving from place to place constantly, not lying down constantly, taking a walk instead of the elevator, use the staircase. Try and do any amount of mobility. Yes. And when you talk to the Japanese whose average age is 100 years old, those guys say that one of the key to their good life is that they are constantly mobile. It may not necessarily mean you have to go to the gym. Just remain as mobile as you can, and involve yourself in even mild to moderate physical activity is more than enough to try and be in good health. You don't have to do vigorous physical activity.
Great. Dr. Bhandari, you have the final word before we take the questions. So how do public at large who are 10 kg overweight, 20 kg overweight, how do they keep their bones healthy and avoid joint injuries or injuries in general?
I think they should take a holistic approach, and whole family should be supportive collectively in managing their weight, and it should be an open discussion so that if they start at early in the life, hopefully they will not achieve or they will not end up being obese and causing multiple medical problems along with both and others.
Okay, thank you. We have few questions with us. So the first question is, how often obesity can be regarded as a risk factor for peri-operative peripheral nerve injury? Who will take that? Please go ahead. It's open, yeah. Peripheral nerve injury. So in bariatric surgery, when we operate because of the patient is in the operation table for maybe 2 hours or in the stretcher or a bed. Some of them have some kind of compression injuries. So do you also see this in orthopedic situations or spine surgeries?
See, one possible cause I can say, because of the obesity, the exposure is higher, the tissues are quite deeper inside, so there is possibility of inadvertent nerve injury because of the difficulty in exposing.
Okay, so Dr. Mazda, there is one interesting question that it is nearly proven that obesity has several adverse effects on the lumbar spine. But does this mean that underweight has a protective effect on it?
I think any extremes of normal is not good. That's why you have something called as a normal, and then you have either under or over. Underweight obviously tends to mean that you're in some sense malnourished or undernourished, and that also has a poor effect on your bone health, on your muscle health, on your tissue health in general. So it doesn't mean that being underweight is a good thing. I think you have to stick to what your normal parameters need to be for your given kind of build, and try and maintain yourself in the normal range.
Okay. There is another question, Dr. Bhandari. Strategies to improve bone health in the obese patients. How can you improve bone health of an obese person?
As we said, it was a multifactorial effect. Not only the nutrition, also there is the physiological effect on the bone health. So first and foremost will be the weight loss, and along with that, correct nutritional supplements, exercises, load bearing exercises, weight training, that will lead to a better bone strength.
Okay, great. There are two questions for me for the obesity related questions. So the first one is, which key points should be taken into consideration while counseling patients with obesity? So I think most of them have been discussed, that uh, the priorities have to be right. We always think that exercise is for weight loss, exercise is for remaining healthy, exercise is for health of your heart, lungs, exercise for your health of your spine, every joint pain, every joint, every bone. So I think remaining healthy is the key, and weight loss is just a part of it. Even if you're overweight and healthy, that is better than being slim and unhealthy. So taking adequate nutrition, whether it's calcium, vitamin D, getting them checked on a regular basis, and eating a balanced, nutritious diet is so important. There is one more. There is one more question. How is gastric bypass related to bone health? So I think we have very openly talked about it. That when you have a weight loss, it impacts bone health. Whether you gain weight or you lose weight, it impacts bone health. But that all these are scientifically studied, and the post-operative counseling is for this purpose only. So I think those patients who have severe bone disease after any bariatric surgery is not because of the surgery, but because of either the program has not supported them well, the bariatric program has not supported well, or the person is not taking the required supplement. So if you stop taking calcium after gastric bypass, it will adversely, or vitamin D, it will adversely affect your bone health. But if you are taking them regularly, it's quite unlikely that somebody will have a major bone issue. So I think these were the main issues. We are almost running out of time. I would thank all the three of my panelists for spending so much time with us. They are all busy surgeons. I know how difficult it is to get an appointment of each one of them when patients are calling them, and I have to use my best contact with them to get appointments for my patients. And Maza, who is smiling here, is a prolific writer. He writes for Midday on a regular basis, and love to read his articles. Thank you so much, Dr. Chinoy, Dr. Bandari, Mazda, for joining me. And we look forward to work together very soon, as the hospitals are open and our operation theaters are working in Wockhardt Hospital. We are
Okay, Raman.
operating in many other hospitals at the moment. Yes.
Raman, thank you for arranging this. It was a pleasure to see everybody. All the best to everyone.
Thank you, and
Thank
bye
you.
everybody.
And
Thank you
thanks
so
to
much.
Docplexus team for this platform, so that we could reach out to many people. Thank you.
Thank you. Bye.
Thank you.
Bye.